Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
A big hello and thank you for all of us who are joining today and for this latest edition of LE&RN Symposium. I'm your host, Dr. Ajit Mule, Science and Medical Director at LE&RN. I would like to introduce you to our guest speaker, Dr. Spencer Gibson. Dr. Gibson is Dianne and Irving Kipnes Endowed Chair in Lymphatic Disorders and Professor at the Department of Oncology, Faculty of Medicine and Dentistry at University of Alberta, Canada. Dr. Gibson has completed his PhD in clinical biochemistry at the University of Toronto and has done pre-doctoral work at MD Anderson Cancer Center. Dr. Gibson has dedicated his life of research to figuring out what affects lymphedema and why people suffer from lymphedema at different stages. Lymphedema, as we all know, is a major lifelong challenge for cancer patients, but not all the cancer patients who are undergoing treatment will develop lymphedema. And this is one of the major questions that Dr. Spencer has dedicated his career to understand. Without further ado, I would like to invite Dr. Gibson. Thank you so much for joining us, sir.
Thank you for that kind introduction. And I'd like to thank LE&RN for this opportunity to discuss my research to the broader community. Before I get started, I'd like to do a land acknowledgement from the University of Alberta. University of Alberta is located on the traditional territory of Indigenous peoples of Territory 6, 7, and 8, and the homeland of the Métis. The university respects the sovereignty, land, history, language, knowledge systems, and cultures of all First Nations, Inuit, and Inuit peoples. With that, I'd like to start with my talk about targeting the lymphatic microenvironment and the hope that this can lead to new therapies. Okay, so it's a pleasure to introduce lymphedema to an audience that I don't have to introduce lymphedema to. And so I'm not necessarily going to talk about the clinical biology behind lymphedema, because most people will know this. But I just wanted to point out that there's like two major categories of lymphedema: primary lymphedema and secondary lymphedema. One is genetic-based mutations that lead to dysfunction in the lymphatics, while the secondary lymphedema is about acquired injury. And some of the common causes and risk factors for this are cancer treatments, obesity, trauma, surgery, and infections. And as was mentioned in the introduction, people with these injuries develop lymphedema, but you could have the same injuries and not develop lymphedema. And the reasons behind this are not very clear. So this was the starting point when I started research in lymphedema to try to understand the basic biology behind this. The same thing is true for treatments. So in treatments, there's manual lymphatic drainage, compression, bandages or garments that control the swelling of the extremities. We got skin care and wound to help with infections and wound healing, as well as exercise that helps with mobility and swelling. And finally, in some cases, having surgery to bypass the lymphatic system is used to alleviate symptoms. And so these are effective treatments, but they address the symptoms of lymphedema and not the underlying causes of lymphedema. So when I started my research program, I had two major questions I wanted to answer. The first question is, why do some people get lymphedema while others do not, even though they have the same risk factors or injury to the lymphatic system? And the second one is, can we develop new treatments that could address the underlying causes of lymphedema so that we would have better outcomes and improved quality of life for people living with lymphedema. So in 2021, when I got the Endowed Chair in Lymphatic Disorders, I established a lymphedema translational research program where the lymphedema patient is at the center of this program. And from the lymphedema patient, we developed a biobank where we collected blood samples from lymphatic patients and got their clinical information. We developed an animal model for lymphedema, as well as molecular and cellular mechanisms to understand the biology behind it. All this will then lead to the understanding so that we can develop clinical trials or clinical studies to improve the lives of lymphedema patients. This was all made possible by Dianne Kipnes. Unfortunately, she passed away last year, and but she was a lymphedema survivor, a cancer survivor, I should say, with lymphedema. And what she found is that there was very little information out there for lymphedema and not a lot of research. And she felt that there needed to be more done in this area. So her desire was to improve the lives of lymphedema patients through research and training. And so the driving force behind this Kipnes chair is to increase research and training in lymphedema to educate people, as well as to get a better understanding of why people get lymphedema. In addition, I talked to the Alberta Lymphedema Association, which is a voice for lymphedema patients in the province in Canada that I live in, and get feedback from them on my research program. And I'm also a board member of the Canadian Lymphedema Framework, which is an organization that consists of patients, caregivers, and professionals to understand and give guidance to the community. And again, this is where I get feedback on the questions that are relevant to lymphedema patients. So the first question I tried to address was why some people get lymphedema and others do not. So this is a famous review by Dr. Roxon in Nature, talking about how lymphedema progresses from damage to inflammation, where you get a strong inflammation response and an increase in growth factors to try to repair the lymphatic system. And if it doesn't repair, then it goes into remodeling, where you get infiltration of adipocytes, you get the expansion of the lymphatic vessels, as well as dysfunction within the smooth muscle, where you don't get any pumping of the lymphatic system. But we felt that there was something missing in this progression, and that was the microenvironment. What role could the microenvironment play in the progression of lymphedema from the initial stages where the tissue tries to repair itself to the later stages where it remodels into something that causes a lot of pain and discomfort in lymphedema patients? And so we believe that this microenvironment could produce stresses that could prevent the repair of the lymphatic tissues. And two of the stresses we studied were oxidative stress and fatty acid toxicity. The first one I want to talk about is oxidative stress. So to look at this, we started with the lymphedema patients and the blood samples that we got from them to try to understand, is there markers for oxidative stress, and does this correlate with the progression of the disease? To do this, we got blood samples from volunteers who had lymphedema. We processed the samples and we grate plasma from these samples, as well as the blood cells, mostly white blood cells like T cells and B cells, and analyze what is present within the blood system. In terms of the plasma, we looked at growth factors and oxidative stress markers to see if this correlates with the progression of the disease. What we found is that as the growth factor VEGF-C increases in lymphatic patients, which other researchers have found, we also saw an increase in oxidative stress markers within the blood. So as the VEGF-C levels go up, so does the oxidative stress. So there's this correlation that was happening. And this could be associated with the progression of the disease. But to answer that question, we needed to go to an animal model. So we went to an animal model that has been well established within the lymphedema field. And this animal model is the tail model, where there is surgery, which we removed skin from the tail, but we don't affect the vascular or lymphatic vessels within the tail. And then we do surgery where we ablate the lymphatic vessels in the tail, but we do not touch the vascular system. So this then causes the swelling of the tail, as you can see in the diagram here. So with the sham treatment, the SAM surgery, we see no swelling of the tail. Well, if we ablate the lymphatic vessels, we start to see swelling within several days, peaking at around 16 to 20 days. And what you can see when we look at the tail is that there's this void in here, which is the collection of fluid within the tissue, with the invasion of adipocytes into the tissue as well. So what we see here is some of the same biology that we see in patients suffering from lymphedema, and we're using this as a model to test the microenvironment. So the first thing we tested were markers for oxidative stress, which is the H-hydroxydeguanate, which is a marker for DNA oxidation. And we looked at this at day 12 of the swelling of the tail. And as you can see from the diagram here, there's an increase in the oxidative markers within lymphatic cells within the tail. And from this diagram here, you can see the lymphatic vessel formation here with the oxidative stress all around it in the lymphatic, in the lymphedema tail, and not, in the sham tail. So this indicates that there is definitely an increase in oxidative stress within the tail starting at 16 days following the injury and persisting out to 16. We also were clearing it, does this correlate with VEGF-C? Because if you remember from the patient samples, there was a correlation between oxidative stress markers and VEGF-C levels. And so we went back to the tail and stained for VEGF-C. It's there in the sham, but we see a significant increase in the lymphedema tail. And what was interesting is that we saw this increase at 4 days. And this is not unusual. We expected this because this is a reaction to the injury. So you want to repair the lymphatic tissue by activating the proliferation of lymphatic cells to create new vessels to repair the tissue. So VEGF-C being up early is what we would have expected. And it stayed up for the entire time. And when we looked at its association with macrophages, which is the source of VEGF-C within the tissue, we see that it also goes up during this period of time, associating with this increase of oxidative stress that happens later. We then looked at cell death, because what happens when you have tissue that has stress, the cells will undergo cell death over time. And that is exactly what we see in the tail. So when we see the swelling of the tail in the lymphatic area, we start seeing cell death at 8 days, even though it's variable, so it's not significant here. But at day 12, remember, this is where we see the oxidative stress at its peak. We see the amount of cell death now increasing, and it just keeps building up over time. We got an increase in cell death at 16. And this is associated with the lymphatic vessels that we see in the tail. So this is, again, a picture of the lymphatic vessel, and surrounding it are the cells that are dying, which, again, is an indicator of the stress that's occurring within the tissue during this time. That's great, but what's the mechanism going on here? How can oxidative stress lead to cell death in the presence of growth factors? Because this is a little counterintuitive in that growth factors should protect cells against cell death because they are proliferating and going forward. So we wanted to understand this. So to do the molecular biology, we got primary human dermal lymphatic endothelial cells from a skin of a male donor, and we looked at growing these cells in tissue culture and then added oxidative stress, which was hydrogen peroxide. We just add hydrogen peroxide directly to the cells, and this creates reactive oxygen species and oxidative stress in the cells. And then what we did is we looked at cell death through a trypan blue exclusion assay, which basically means that live cells exclude the dye, dead cells take up the dye. So we just look at blue or blue cells, and the ones that are blue are dead, and the ones that are not are healthy. So we can look at the amount of cell death that's going on. And it's a really nice assay because it covers all forms of cell death. It is easy to do, and we can have a picture of what's happening in the cell. So what we did is we treated the cells with hydrogen peroxide. We added the growth factor VEGF-C to the cells. And what we found is that in the combination of hydrogen peroxide and VEGF-C, we get more cell death. And we get more cell death when we have approximately 10 nanogram per mil of VEGF-C, which is higher than what you would normally see, but is in the range of what you would see in a lymphedema patient. So what we see, this increase in cell death in the presence of hypoxia, which correlates to what we see in the animal model, and it correlates to what we see in the patient's blood. But why is this occurring? So one of the things that happens when you treat cells with VEGF-C is that they go into proliferation. And to proliferate, you have to replicate your DNA. And this makes the DNA more susceptible to damage. So we looked at a DNA damage marker called gamma H2X, and we looked at the levels of this marker within cells treated with hydrogen peroxide, VEGF-C, and together. And what you can see, obviously, from this diagram is that when we combine VEGF-C with hydrogen peroxide, we increase the level of DNA damage that's occurring within these cells compared to what we have with just hydrogen peroxide alone. But is this damage is being caused by the activation of the VEGF-C pathway? So VEGF-C binds to a receptor on the cell surface called VEGF receptor 3 and activates the signaling pathway to induce proliferation in lymphatic endothelial cells. So there are inhibitors to this specific receptor, and could we reverse the amount of cell death by inhibiting the VEGF-C receptor signaling? So this is what we did in this diagram, where we looked again at the DNA damage that occurs in cells, and we looked at it in the presence or absence of an inhibitor to this receptor. And what we found is that if the receptor is inhibited, the increase in cell death we see with VEGF-C and hydrogen peroxide is reduced. Not by zero, because these inhibitors doesn't block all the signaling in the cell. But what it does do is it reduces this ability of the cells to enter proliferation, and which also reduces the amount of cell death we see when we do this combination. So to summarize kind of what we think is going on in the lymphatic cell under oxidative stress is that in the presence of VEGF-C that binds to its receptor on the cell surface, it induces a signaling event that causes the cells to proliferate, and we have other data showing that this is exactly what's happening. But in the presence of the microenvironment of oxidative stress, this then leads to more DNA damage, which then triggers another pathway leading to cell death called apoptosis. And so the cells are no longer able to proliferate, they're no longer able to repair, and therefore you can get the progression of the lymphatic system. If you want more information about this, we published this in 2024 in the International Journal of Molecular Science. So going back to my microenvironmental stress model, as some of you might have inferred, this oxidative stress increases during the process of lymphedema, but is not there at the beginning. So it's not a precondition to get lymphedema. There has to be something else going on to lead to the oxidative stress, to lead to the progression. And one of the risk factors for lymphedema is obesity. And so one of the things we were interested in is that does fatty acid toxicity associate with lymphedema? This is a well-known toxicity that's associated with obesity and liver disease and diet. And does this correlate with the progression that we see in lymphedema? So to answer that question, we went back to the example of liver lipid toxicity. And so what this shows is that when you have increased saturated fats that enter a cell, in this case a liver cell, you get a stress response going on within the cell called endoplasmic reticulum stress, which leads to increased oxidative stress and induction of apoptosis. And when we saw this, it kind of rang a bell in our way that, well, wait a second, we just saw oxidative stress in lymphedema cells. We showed that it can lead to apoptosis. And this is what's happening in lipid toxicity within the liver. Does this occur in lymphedema patients? To answer this question, we have to go back to our model, where we are looking at the lymphedema patient, and we went back to their blood, and we looked at their plasma, and we said, can we look at the lipids in the plasma to see if there's any difference between lymphedema patients and patients that are people that do not have lymphedema? So we took these plasma samples and we went to a collaborator, Catherine Fields at the University of Alberta, that has a gas liquid chromatographer that can identify all the species of fatty acids within the blood, and did an analysis on our lymphedema patients as well as our healthy controls to see if there was any differences. To make a long story short, what we found is that the ratio of polyunsaturated fatty acids versus saturated fatty acids. So this is a difference in the double bonds within the fatty acids. So saturated fatty acids have less double bonds than polyunsaturated fatty acids. And this ratio we calculated was lower in lymphedema patients in their triglycerides and colorectal esters than we find in our controls. This suggests then that, relatively speaking, there is a higher level of saturated fats in the blood of lymphedema patients as compared to others. So suggesting, again, that there might be lipid toxicity that's happening within the tissue. When we looked at BMI, which is a surrogate for obesity with all the caveats of the limitations of doing BMI, we found that there was no correlation with obesity. So no matter if you had an BMI of 20 to 25 or a BMI over 25 or 30, it didn't really matter. The correlation in the fatty acids, we stayed about the same, which we found interesting in that, again, it associates with risk factors and causes that there is this issue in terms of what's important and what's not. So we went back to our animal model, and we knew that from our patients that obesity wasn't a factor in this ratio that we were looking at. So we specifically developed an animal model where we looked at diet, but we didn't put the mice on a diet to the point where they were obese. So the point here is that the mice that I'm going to show you in the next several slides were not obese. They were just given high-fat diets of various different degrees. So what did we do to the mice? So we gave them 3 different diets. The first diet was their general diet that they always would have, which is called a chow diet. And the polyunsaturated to saturated fat ratio is really high. It's 3.5 in this diet. So then we gave them a high-fat diet, which is closer to what you would find in a Western-style diet. And the ratio there between polyunsaturated and saturated fat was around 1. The next one was we wanted to give the mice a diet where we would have a really low ratio. And this is a high saturated fat diet with a polyunsaturated saturated fat ratio of 0.14, which is extremely low. But we wanted to see the differences. So we wanted to make sure that we had a range here. We kept them on the diet for about a month. And then we did the surgery. And then we looked at the swelling over 28 days. We then took the tails and we took the blood and we looked at the markers for lymphatic lipid toxicity. So when we took the blood, we also went back to our gas chromatography and looked at the ratio of polyunsaturated versus saturated fats. And what we saw was that in the high saturated fats and to a lesser degree in the high fat diet, we start seeing this lowering of the polyunsaturated saturated fat in these mice, which correlates with what we see in the lymphatic patients or lymphedema patients. And so what we thought was that this could at least approximate what is happening in the lymphedema patient. When we looked at the swelling of the tail, what we saw was that at the early stages, the high-fat diet and the high saturated fat diet had increased swelling compared to the chow diet. But they kind of came together around day 16, where there was no significant difference. But when we started getting out to about 24 days to 28 days, the high-fat diet mimicked the chow diet, but the high saturated fat diet, as opposed here, remained high. In other words, the lymphatic tail was not resolving itself at these times. And you can see from the immunohistochemistry or the histochemistry, I should say, of the tails here on the various diets, the lymphedema tail at the high saturated fat diet had much more liquid within the tail, defining the swelling, than we see in the other diets. So this was interesting, but does this correlate with what we previously saw? So we looked at these tails at day 28, and we looked at the the oxidative stress marker that we previously showed was elevated in lymphedema. And what you can see here in the red box is that at the high saturated fat tails that we looked at oxidative stress in lymphedema, there was a significant increase in the oxidative stress in these mice, which is, again, associated with this increased swelling that we're seeing, where we saw a lot less in the high-fat diet and the chow diet. But remember, this is at day 28, where the tails are starting to reverse. If we saw this at day 16, there would have been a higher level of oxidative stress in the lymphedema patients as compared to the controls. That's good, but what's going on in the cells? What is this high saturated fat doing to lymphatic cells? So again, we go back to the cellular molecular mechanisms. We go back to our primary human dermal lymphatic endothelial cells that were taken from a patient. And we, instead of treating them with hydrogen peroxide, we treated them with saturated fat. In this case, it's stearic acid that we are treating the cells with. And what we found is that when we treat with stearic acid and we increase the dose, we increase the amount of cell death, which is an indicator of lipid toxicity. And we saw this in our human dermal lymphatic endothelial cells, or HDACs, HDLEX for short. But when we look at vascular cells, in this case, it's the human umbilical cord vascular cells that we have in the tissue culture, we see that stearic acid can induce cell death in these cells, similar to the lymphatic cells, but to a lesser extent. And this will become important later in my talk. We also saw this in rat cells that we got from a collaborator, in which the lymphatic cells also induce cell death under stearic acid treatment. So this all makes sense. When we looked at the amount of cell death now when we added hydrogen peroxide to this, we saw that we can further increase cell death. So this is a negative feedback loop if you think about it. So it is the saturated fats inducing cell death. We add hydrogen peroxide to it, and now we get even more cell death. So as the microenvironment becomes more stressed, then we start to see more cell death in lymphatic cells. So the model here, what we think is happening is that we have these saturated fats entering the cell, and they're causing stress through the endoplasmic reticulum. I have more data showing that the stress is through the endoplasmic reticulum, which then leads to increased reactive oxygen species in the cell. And this increase in reactive oxygen species will lead to cell death, because if we block reactive oxygen species, we can block the saturated fat-induced cell death in these cells. So that's kind of the stress that is going on within these cells. But the big question is, so what? How can you actually treat these lymphatic patients to reverse this stress that's happening in lymphatic tissue? To do this, we went back to our lymphedema model, and we did the same diets of high saturated fat and chow. But what we did with the high saturated fat is that we switched the diet at day 6 after the surgery to see if we can reduce the amount of swelling in these mice. what we see here is that when we change the diet at day 6, and this is when we start to see this increase in swelling of the tail within our model, it follows the same pattern as we saw before. But in the mice with the high saturated fat diet, we see that the swelling persists. But once we've switched to the chow diet, it looks exactly like the mice that were on the chow diet from the beginning, which we found really exciting because this suggests that you can change the diet and then you can change the progression of lymphedema. We are currently looking at changing the timing of this to see what happens at earlier times and at later times and over a longer period of time, which is, in the future. But this is really important for us to know that we can change the diet, we can change the lymphatic swelling or the lymphedema swelling. When you go to the tail, when you've changed this diet, does the stress in the tail change? And so again, going back to our oxidative stress marker, in the high saturated fat diet, we see stress around the lymphatic vessels. But when we change the diet to chow diet, that stress goes away. And so we believe that then this is also changing the stress within the microenvironment over the progression of lymphedema. So I've kind of hopefully shown you that there is stress in lymphatic lymphedema tissue, and that lymphatics react to this stress that allows for the progression of lymphedema, and that saturated fatty acids are part of this. But when I went back to the lymphedema patients and I presented this data to them, the first thing they said to me was, I was on a diet. I tried changing my lifestyle and my lymphedema did not change. Why? I didn't have an answer for that. I have a lot of hand waving, but I didn't have an answer. So we went back to our biobank and to the literature and said, what's going on in terms of fatty acid transport, and how is the cells reacting to this stress? And so what happens with saturated fatty acids, and all fatty acids for that matter, is they don't enter the cell passively. They have to be transported into the cell. And one of the fatty acids that's associated with lipid toxicity in the liver is a fatty acid binding protein 4, which binds to saturated as well as polyunsaturated fats and transports them into the cell. If this protein is bound to saturated fatty acids, it contributes to cell death in liver cells. Is this occurring in lymphedema? Well, there was another set of literature that came out that lymphedema endothelial cells, as well as vascular cells, contribute to the secretion of VEGFs, of FFBB4 in the circulation, as shown here with the knockout in the vascular system and the lymphatic system for that matter, showing reduced levels of FFB4 in circulation. That's great, but it's both vascular and lymphatic systems that are affected. What happens if the lymphatic system doesn't really matter in this case? Well, it was researchers looking at primary lymphedema that gave us the clue that we have to go after this. And that is that FFBB4 has been shown to be mutated in primary lymphedema in several patients. And talking to geneticists that do this on a regular basis, they told me that it is not a one-off or rare event. They do see it quite often. So we think that FFBB4 is playing a role in our lipid toxicity model. To look at this, we're kind of reversing what I've done previously and went back to our cells to say, molecularly, does FFB4 play a role? This is a rare occurrence where I asked my lab to do an experiment, and after it was done, they run to my office saying, you've got to see this. This rarely happens. This is what they showed me. What they showed me was that the vascular cells that we were looking at, that I showed you that were less sensitive to oxidative stress, and less sensitive to saturated fat-induced cell death, had very little FFB4 expression, while our human dermal lymphatic endothelial cells had significant expression of FFP4, suggesting that this is playing a role in the toxicity. To prove this, we knocked down FFP4 with siRNA and looked at the toxicity following treatment with stearic acid. And what you can see in the graph here is that when FFP4 is knocked down, stearic acid's ability to induce cell death in these cells is also reduced, suggesting that this is playing a role in the lipid toxicity that we were seeing. Furthermore, when we used an inhibitor against this FFP4 protein, we could also reduce the amount of stearic acid-induced cell death by over 50% in our lymphatic patients, or I'm sorry, in our lymphatic endothelial cells, suggesting again that this protein is playing a role in the lymphatic lymph toxicity within lymphatic cells. So then, to prove it, or to at least correlate it, we had to go back to our animal model to say, is FFP4 there in our tail lymphedema model, and can this play a role in the swelling? So what we did is we took the FFP4 inhibitor and we treated the mice with it in the context of high saturated fat diet versus chow diet. The inhibitor had no effect on chow diet in terms of the swelling. But what we found is that in the high saturated fat diet, in the presence of an FFP4 inhibitor, we can reduce the amount of swelling by 50%, which is very similar to the amount of cell death reduction we saw in our lymphatic cells. So we suggest here that FFP4 is playing a role in the lipid toxicity that's occurring within the tail model in mice that were fed a high saturated fat diet. To show that lipids are playing a role in this, we actually looked at the tissue and stained it for lipids with a red O staining. This is a stain that stains neutral lipids such as fatty acids, and looked at the amount that was in the tissue. And so in high-fat diet that has lymphedema in the tail, we see a lot of lipids in the tissue. But when we inhibit FFP4, the amount of fatty acids or lipids generally in the tissue is greatly reduced. And it's similar to what we see when we change the diet from high saturated fat to chow diet. So that was very satisfying. But again, at the end of the day is, what does this mean for lymphedema patients? So we go back to our biobank, go back to our plasma, and say, we know that FFP4 is secreted in the plasma. So what is the level of FFP4 in our lymphatic patients compared to our controls? This is what the data shows, and it kind of blew me away in that lymphedema patients had almost 3 times higher levels of FFP4 in circulation than control patients. And some of these control patients are cancer patients that do not have lymphedema, suggesting that FFP4 could be a biomarker for the development of lymphedema moving forward. This is, again, an area of active research within my lab. And in the bottom graph here, it just shows breast cancer-related lymphedema versus non-breast cancer lymphedema, because most of our samples are breast cancer lymphedema in our biobank, but not all. And we still see this increase in FFP4 in the non-breast cancer lymphedema. And the reason, again, why we separated it was because in the literature, breast cancer patients at the time of surgery have high levels of FFP4 compared to controls. Again, suggesting that this could be a biomarker for patients getting lymphedema later. So in terms of treatments then, there are suggestions that we can use inhibitors or diet to change the microenvironmental stresses and the progression of lymphedema through these interventions. For more information, this was published in September of this year in the journal EMBO Molecular Medicine where we go into much more detail of the experimental designs and readouts of what's happening in lymphedema. I warn you, it's a very dense read. So for people in the audience that are more on the clinical side of the spectrum, one of the things that we want to do is move from the biobank tissue culture realm into the clinical trial, clinical study realm. How are we going to do this? Well, just this fall, a new institute was created at the University of Alberta called the Dianne and Irving Kipnes Health Research Institute in honor of Dianne Kipnes and her desire to increase the amount of research and translation to patients across many different diseases. And so this health institute has three major pillars. It has the health research translation, trying to translate discoveries to patients. Artificial intelligence, because that's the big thing at the moment, and how this can transform healthcare and health research. But the final one for us is the lymphatic research and training pillar. This is the one that is going to be designed so that we can increase the amount of training and to cross that translation back to the patient. So being in the rehabilitation medicine area, how can we apply the discoveries we make within the lab to the lymphedema patient? So what are we doing in this space? Well, we are just at the starting point now of trying to design and get money for developing translational programs to eliminate lymphedema microenvironmental stress. How we can do this is through diets that are low in saturated fat and see if we can have effect. Supplements that we can use in order to alter the stress within lymphedema patients, and using FDA-approved drugs that are already out there that could have an effect on the microenvironment within lymphedema patients. So this is ongoing research, and I'm hoping that in several years they'll invite me back to show us how we are translating this to the actual lymphedema patients. But this is just a little tease in which showing that we could add supplements to improve the microenvironment. This is, again, in tissue culture, looking at lymphatic cells. We added linoleic acid, which is a polyunsaturated fatty acid, that we've shown is low in lymphedema patients, and added this in molar concentration equals 2 saturated fatty acids because both of those bind to FFP4. So in principle, it could compete with each other for the transport of saturated fats into cells. And to show that we can reduce the amount of lipid toxicity in these cells and the amount of cell death. And so what you see in this graph is that linoleic acid can almost eliminate saturated fatty acid-induced cell death by stearic acid. And we've shown other experiments showing that it reverses everything that we see in terms of the biology behind lipid toxicity with saturated fatty acids. So this is something that we are going to go into a mouse model and going to further develop to say, could we then figure out supplements that can reverse this type of effect? So this research cannot be done without a team of highly qualified personnel. Karina Gomez is my research associate who did all the animal work and was the lead on the lipid toxicity studies. Zaina Hosseini is my PhD student who did the oxidative stress studies and is now looking at hypoxia and its role within the progression of lymphedema. Nirav Patel is my clinical coordinator who consented and took blood from the lymphedema patients and controls. And Dianne is my research technician who coordinates everything within the lab, and Catherine Fields, who was the expert on the fatty acids that we needed. I just want to also thank the patients that participated in these studies. Without them, we would be lost. And the Alberta Cancer Research Bank flow facilities and imaging facilities that provides us with the samples and technology we need for our studies. Finally, and I'm pretty much on time, is what you want to take away from this talk is that there is hope for effective treatments, understanding the biology. Our whole motto is we want to go from the bench to the bedside and back again. This is what we would want to do, and I'll be happy to take questions.
Thank you so much, Dr. Gibson, for sharing this fascinating research and showing us the possibilities for all the patients out there who are suffering from this debilitating disease. Without much ado, I see there are a lot of questions coming in. I'll start putting them to you. The first one being, given that we know that MLD or manual lymphatic drainage can accelerate the lymphatic flow, even in circumstances of lymphatic damage, can we test out whether MLD can reduce the level of VEGF-C and slow the cell death?
That's a really good question. And it is right that manual lymph node drainage can speed the flow of lymphatic fluid. And one of the hypotheses, and it's just an hypothesis, is that it also changes the stress and but not just the VEGF-C, but the mechanical stress that the tissue is under as well, the pressure, in other words. And so by just relieving the pressure, you can also relieve some of the stresses within the microenvironment. These are open questions because you need to have an effective model to look at this. And right now, to my knowledge, there isn't really a good model to look at manual lymph node drainage beyond the patient itself. And the patients aren't going to let me to take chunks of their tissue to look at. So I think you're along the right lines here. And it's something that we probably should have more clinical studies on. And it's something that we're going to be looking at in the future.
Definitely, sir. Another question that comes in is, can we target chronic oxidative stress through diet? Because insulin resistance is known to create chronic oxidative stress. Can we target insulin resistance or through a carbohydrate restricted diet?
Again, a very good question. We have thought about that. Again, it goes back to the lack of clinical studies in which they were looking at these factors within the blood when patients are under these different diets, because there has been a lot of work done on oxidative supplements. I know there's work on the ketone diet and others as well, thinking that it could improve. I guess my answer to that is that it could, but it's only part of the story. So I don't suggest that just changing a diet, you will immediately see an improvement in lymphedema. I think that you have to do this in combination with other treatments in order to see the effect long term. And again, I emphasize that there needs to be clinical studies on this. We're in the wilderness here. This is just at the starting point. So I wish I could have a definite answer for you on that. Anecdotally, with what's in the literature, it doesn't seem to have a major effect. But again, these studies are kind of one-offs, and we need to have more controlled studies to answer that question.
Sure. Another question on the same lines is, could you elaborate on the carbohydrate content in the diet that you used for animal tail model? And if there is a high carbohydrate content in that diet, and if that is not the case, what do LECs use as an energy substrate?
Oh. What I can tell you is that in the diets that we used, we kept everything the same. So in other words, the calories from carbohydrates, the calories from fatty acids and sugar and protein, we kept the same. The only thing that we changed was the ratios of polyunsaturated versus saturated fats in the diet. So even though I can't off the top of my head tell you exactly the carbohydrate done, it is similar between the chow diet, the high fat diet, as well as the high saturated fat diet.
That's fine. Another question that we have is, can we change the diet years after the initial insult to
Yeah.
lymphatics has caused a late
Mhm.
onset of lymphedema?
Right.
And can this possibly explain why some people don't develop lymphedema? until the years after a circumstance where some damage has
Mhm.
occurred?
Um, Maybe. We have to look at markers of that in patients who are going into surgery and then tracks them over. And the problem in the patient population is that we lose them after surgery because of when they finish their treatments, they leave the healthcare system and they go to their private doctor. And it's really hard for me looking at the medical record to see this, to try to get at this. But I know there's other researchers in Toronto and around the world that are actively looking at that question. Now, the other part of that question is that now that you have lymphedema and it's progressing and you've had it for years, can this then affect it? You just described aim 3 of my national grant that we are trying to get funded so that we can have a study looking at exactly that question, working with a nutritionist here at the University of Alberta. So we don't know.
Sure. Uh, how do high levels of FABP4 become present in lymphedema patients? Do you have any idea about that, sir?
In the literature, it states that if you have breast cancer, for example, the actual tumors secrete FFBP4. And so that's why in that patients with breast cancer, you see this higher level. The problem is that the lymphedema patients, the breast cancer lymphedema patients I've shown you, haven't had tumor in years since the surgery and the treatment. These are survivors. They're not people that are actively under treatment or have metastasis. So where is the FFP coming from? That is a really great question. One of the areas that we're interested in looking at is hypoxia, because that has been shown to increase the levels of FFPP4 in circulation, as well as other mechanisms and cell types can release it, such as fat cells, adipocytes. So this is an unopened question. It's one that we are interested in looking at. But the short answer to your question is no, we don't know where it's coming from.
Another question is, can we get patients start diets low in saturated fatty acids? And are there medications that you mentioned that are available?
Again, I caution anybody in terms of diets to refer to their physicians in terms of it, because there's other aspects that could change based on your health status, which is just not lymphedema per se. So I am not advocating people going on diets. What we need is a clinical study of patients who are well controlled on diets to see if there's actually going to be an effect. Because I think that if you go on a diet, there's so many other things happening. I think that it would be hard to control for to get the effects that you would desire. So I would wait until we have the clinical data before trying to do diets, but by all means, discuss this with your physician in terms of what's best for you.
And another question is, what's the name of the supplement that can reduce toxicity in the lymphatic environment? And
These are ongoing studies, so I can't comment on something that I can't prove.
no, definitely. That's The other question is, there's a lot of work focused on lymphatic endothelial cells, the initial
Mhm.
lymphatic vessels. Have you looked at how these saturated fats and oxidative stress affect the collector endothelial cells? And what do we know about
Mm.
smooth muscle cells?
Yes. Um, we haven't gone down that far yet. We have looked at uh, micro vascular cells, which is kind of in between the vascular and the lymphatic cells, and see the effects on that. And it's exactly the same that we see in dermal lymphatic cells. So the biology here is the same. In terms of the smooth muscle, that is studies ongoing, because you could also have said what's happening to the B cells and the T cells and the macrophages. And those are all areas where we are interested in. What I can tell you in terms of the immune response, I can't tell you anything about the smooth muscle right now, is that it reverts back to where it was before. So it goes from the inflammation state to a less inflammation and infiltrative state in the low uh, in the low saturated fat diets. So we think that it's reversing a lot of the effects in the microenvironment. But again, I caveat that this is in the mouse model, not in lymphedema patients.
Sure. Another question is coming from a patient. They would like to volunteer for a clinical trial where it is happening. Can you suggest any place that,
Oh, uh, they haven't started yet. I'm waiting for the money. So as soon if we have it in place and approved, we will definitely go through Learn and advertise it for anyone who's interested.
That's exactly what I would also suggest to all the patients. Please have a look out on our website. We keep an updated list of all the clinical trials that are happening around the world, which are focusing on lymphedema and lymphatic disease. So if you're interested in, and if you feel one of the trials is suitable for you, you can always visit our website and get more information about that. Uh, there's another question coming in, sir. Do you demonstrate a reversal of some of the swelling when the high saturated fat diet is changed? Do you
Mhm.
think there is a point that there is already much damage done to help the swelling?
Mhm.
Once the remodeling happens, would there be any healing or reversing of that? It would major change that major changes would occur in the diet and using inhibitors.
So I apologize a bit for the hand waving here because it's part of ongoing discussions that we have in the research community about this. So in the tail model, you can reverse a lot of what's happening. But to be clear, you can't get it back to where it was before. So other labs have shown and have told me that you can get it down to a lower level of swelling, but it never actually goes to where it was at the beginning. And again, this could be because of the fibrosis, which I didn't talk about, and the remodeling that's happening. You only can get it so far, and that you probably need something else to move it forward. I guess my point to that is that if we can get it to a point where you do not have the negative effects of pain, infection, and mobility issues, these other issues could be things that patients could live with if we can get it to that point. So I think there's a spectrum here that we can work with, but I am not advocating that we could get it back to where it was before. I don't believe that.
Sure. I think we are almost at time.
Mhm.
I would like to thank Dr. Gibson for a wonderful presentation today.
Thank you so much, and happy holidays to everybody.